Okay, I think we should start. So I'm going to hand you over to our chair for today, Dr. Ian Bernstein.
Thank you very much. And if we could pop the agenda up. Good afternoon and welcome. My name is Ian Bernstein and I'm chairing today's webinar. I'm the Clinical Director for Musculoskeletal Health for the NHS London region, as well as working in a community pain service for Connect Health. Connect Health has been running the Change webinar series for 2.5 years, covering a diverse range of topics, including clinical topics such as rheumatology, chronic pain, mental health, and long COVID, as well as themes such as quality improvement, health inequalities, and workforce strategy. The recordings for all of these can be found on the web page. Today is the 23rd webinar in the series, and our topic is Community MSK, How to Alleviate Elective Care Pressures. We have a great lineup of speakers, and you can find their biographies on the web page. Each presenter will give a short presentation followed by any immediate questions, but we will take the majority at the end, and I would encourage you to post your questions in the Q&A. The backdrop for this webinar is that there are just over 7 million people in England waiting for NHS hospital treatment, including 785,000 people waiting for hospital orthopedic appointments or admission. As we'll hear today, there are also many people waiting for community musculoskeletal treatment. So tackling the NHS backlog is a huge challenge, compounded by winter pressures and staffing issues. The NHS 23-24 operational planning guidance was released on Christmas Eve. It sets out the critical actions that will support 3 priorities: to recover core services and productivity, to make progress in delivering the long-term plan, and to continue transforming the NHS. Our webinar today will help the clinical community by discussing the actions in the new improvement framework to reduce community musculoskeletal waits, and by learning from our speakers about their innovative approaches that they are taking in their different roles. Taken together, the 2 documents, the planning guidance and the community recovery framework, for the first time outline an approach to recovery across different settings of care for musculoskeletal conditions, rather than just focusing on secondary care. This is important when you consider where patients are seen and the NHS costs that have driven previous policy. Could I have the next slide, please? So to set the scene for our webinar today, let's reflect on where patients are seen. So this chart shows the patients in a population of 330,000 just immediately pre-pandemic, and it shows where they had contact with the NHS for a musculoskeletal disorder and what the costs were associated with that. What we can see on the left-hand column is that 75% of people had contact with their GP, and this cost 13% of the programme budget for musculoskeletal conditions, including the NHS prescribing costs. Now, of those 75%, the vast majority were seen in primary care and not referred, but a proportion were referred. And what we can see from this chart is that as people move through more specialist settings of care, the costs increase. So 22% of people are seen in community, outpatient and A&E settings, costing 4% of the programme budget. And 3% of people are admitted, either for elective or emergency surgery or for inpatient musculoskeletal conditions, and this costs 43% of the budget. We need to bear this in mind as we discuss the context for transforming pathways of care. So we move now to our first speaker, and it gives me great pleasure to introduce Kate Jackson. Kate is the Assistant Director of Community Transformation in the Chief Operating Officer Directorate in NHS England. Kate has a longer slot to take us through the new improvement framework and answer your questions. Kate.
Thank you, Ian, and thank you everyone for joining today and for inviting me to speak about the new Community MSK Improvement Framework that was published earlier on in January to support the reduction in waiting lists in community MSK services but also improving outcomes and experiences for patients, and ultimately supporting the alleviating elective waits. Next slide, please. So just to, I suppose, follow on from Ian's introduction really around context from a national picture in particular, focusing on the numbers and the huge challenge that we have in community in terms of people waiting, and also being able to demonstrate how many people are waiting. We developed a SITREP as part of the restoration of services after the first wave at NHS England. And here's the latest results that we are able to share at the moment from November. And this is not a surprise. This is very, very consistent in terms of after both waves, particularly after Omicron. We've had some changes in some of the questions that we've asked to focus more on weight rather than restoration over the past 6 months, but it's consistent in terms of our greatest challenge being in community MSK services, and followed very swiftly from podiatry and podiatric surgery. Just in terms of context, this is an aggregate collection. It is just over 11% of community providers, but we are very confident that this is over 80% of community spend in terms of who is submitting this data. So it's not perfect data, but it is data. And it is also there are opportunities and potential for this to be improved, and I'll go on to that maybe a little bit later. In terms of granularity, this is everyone waiting, so this would have include the person referred yesterday, but also the person who is waiting possibly over 52 weeks. Next slide, please. Thank you. So just to talk about community MSK in terms of the wider picture at a national level, in terms of achieving, how are we going to achieve across all of our systems across the country the vision that was set in terms of enabling best MSK health within all communities, and we've taken a really strong stance in terms of how this work nationally was co-produced. We worked in partnership with people and with patient groups, ARMA versus arthritis, etc. And we focus very much on encouraging, and as part of the improvement frameworks, local leaders to make decisions with people and with their local populations and partners, ensuring that ICBs are able to deliver the 4 key areas of purpose, enabling those boards to work alongside meeting those national objectives, but also their local priorities that focus on population health in terms of helping people to grow well, to work well, and to age well. We have absolutely looked in terms of pathway and system settings, and our focus around primary and community working closer together, pre admission, post hospital, out of hospital care, in terms of following that patient along. So the improvement framework in development was has not only actions for community MSK services, but also for primary care and secondary care, and supports, as I'll go on to in a second, that partnership working across all systems. Next slide, please. Thank you. As Ian alluded to before, the improvement framework is a product of 2 years' work, really, in terms of recovery in community. And you'll be aware that last year in the operational planning guidance systems were asked to develop and agree plans for a reduction of community waits across adults and children and young people services, and ensuring that they were complying with national reporting of data in terms of the SITREP, but also in terms of other areas of data collection. This year, systems are being asked to monitor that progress in terms of reduction, and the technical guidance is very clear around submission of data in terms of numbers of children and adults waiting for community services. It also very clearly states as one of the national objectives for community health services that direct referral and self-referral routes to a specified number of community services, which includes community MSK services, enhance their self-referral routes and direct access across their system. Systems are being asked to consider how this will be put into action and to report back with their plans, in which we are really has been aligned ultimately with the publication of the Community MSK Improvement Framework, supporting those systems to reduce those waits as they are very being asked to do in the financial allocations that they've been given, but at the same time ensuring that we're delivering best outcomes and experience for patients. Next slide, please. Thank you. So just in terms of an introduction to the framework, this is very much a collaborative piece of work across all providers of community MSK services, lived experience partners, national clinical leaders and commissioners, and has been an accumulation, I think, of the last 2 years' work of the Best MSK Health programme. We were very keen and clear in our aim that we wanted to support systems to be able to define what was required in order to meet these objectives in terms of principles, in terms of definitions of what a priority patient is, an acceptable wait time in terms of a threshold rather than a standard nor a target, and some recommended actions for, as I said before, across primary, community and secondary care, across that pathway, and also to be a document that supports systems in how to deliver. And so there are embedded resources within the framework document that supports providers and commissioners to deliver what is being asked of them. Next slide, please. So just to go into detail in terms of those defining principles for reducing waits. ICSs should be already, but it was very clear around enabling local leadership and local AHP, MSK leadership to adapt and adopt these principles to ensure that we are accountable, that systems are accountable for delivering services that are aligned to population need, and also availability of resources across a system. To take that kind of coordinated and collaborative approach, I've discussed how important co-production was in the development of this publication, and this is ultimately we're doing what we were wanting to see ultimately in terms of this is a co-produced piece of work nationally. It's an expectation that this is done at system and provider level. We are very keen at equality analysis, ensuring that services are delivered to meet the needs of local people, undertaking that population health approach, reducing health inequalities, and paying real particular attention to the demographic of your area and your system. It goes without saying that these the fourth principle is around applying best practice in terms of guidance and pathways across the system in terms of condition specific guidance, and ensuring that all clinical decisions are based on evidence, and that communication with people uses personalised approaches, for example, shared decision making, and that we ensure that we are listening to people's individual preferences and values. Next slide, please. So as I said before, it's the first publication of its kind to define what community MSK services should look like. We have been clear around community triage and also community therapies as those two functions, and also what we would expect priority patients and providers of MSK services to be defining their priority patients as people who've had recent surgery or procedure requiring rehabilitation, patients who've had a recent injury, fracture or dislocation requiring rehabilitation, and patients with acute or complex needs that are experiencing high levels of pain or a significant loss of function that's affecting their daily life. That includes their inability to work or undertake caring responsibilities. And I think it's really important to understand that this is, as a framework, the first time that this has been defined and described in this way. Next slide, please. In terms of specific actions for community MSK, I'm not going to go through all of these. I think that a lot of them have been described already. But again, it is very clear what we're expecting community MSK services to act upon as part of their system. And the ICBs, we wanted it to be a really practical framework, to be honest, so that people from providers, but from commissioners could turn up at the meeting with this framework to say, this is what we should be doing. Let's work together to get this done, and this is how we should do it. Next slide, please. And this is my final slide, Ian, just so you know that I'm trying to keep to time, because I know there's a lot of detail in here, but obviously happy to take questions. In terms of actions and wanting to give providers and commissioners resources to be able to deliver and to transform services. There are embedded links, but there are actions aligned to this to support delivery. So that includes utilising personalised care approaches, for example, patient-initiated follow-up, which is supporting outpatient transformation already, and will support in how community MSK services can work alongside our outpatient and secondary care partners, making best use of digital resources, and utilising group interventions, for example, Escape Pain as an example of that. Personalised approaches in terms of peer support, supported self-management, health coaching, and ensuring that kind of psychosomatic approach and ensuring the mental health of our patients is integral to the interventions that we're providing MSK, so that now called talking therapies, IAPT services are part of these conversations. And hugely importantly, that the system includes our partners in the charity, social enterprise and voluntary sector, alongside yourselves in the independent sector of providers of commissioned community MSK services. And I think that we may be able to have a chance to talk about that a bit later. Thank you, Ian.
Kate, thanks very much for a really helpful introduction to the framework. We've got some questions coming in, and please do keep posting them in the Q&A. The first question for you, Kate, is what do you think are the 3 most important areas to support successful implementation of the framework?
Thank you, Ian. I think for me,
sorry, can I just pause for a sec? Can I ask if we can pop you on full screen? We don't need to see the slide for this. Okay.
Sorry if anybody's eating. Thank you. I think in terms of success measures, and there are 3 huge challenges for me that we need to focus on in terms of being able to deliver this framework for it to be successful, and that's workforce, data, and commissioning. And I think we know we've got a huge issue in terms of supply, retention and recruitment in our workforce, and for us to think about our workforce in terms of MSK practitioners, and looking at kind of outside of the traditional box, I suppose, in terms of registered and non-registered members of staff, in terms of workforce who have the skills and experience to deliver what our patients need. I think there is nationally we've been doing work in terms of influencing the national workforce strategy. I know there's work going on in terms of the department and UK Active and the Office for Health Inequalities and Disparities work on the MSK hubs and working with the leisure sector in terms of increasing physical activity, getting people back to work. Obviously, as an occupational therapist, you know, the absolute benefit that occupational therapists can add value to a community MSK service. So workforce in terms of a challenge, but also about thinking outside of maybe the traditional box. Community data, again, huge challenge. 3 years ago, we didn't have the data. I've just been able to show you at the top of my presentation. It's not perfect, it's not granular enough at the moment, but it does demonstrate a picture of what is happening out there in community, and so that we can use that to influence policy. And we do have a data improvement plan that looks at faster data flows, more real-time data that will be of huge benefit, be able to give us that granularity that we're missing in terms of being able to improve our services. And thirdly, commissioning. Work that we've done and pre-pandemic has, you know, shown us the unwarranted variation in commissioning of our community MSK services, and how we could, I think for me, next steps for my area of work would be around developing some commissioning guidance that looks at contracting and standardizing outcomes in terms of what should be commissioned in community MSK, that kind of feels like more detail than the framework gives. So, and I think that will come, like the government's major condition strategy, which was published, I think it was earlier last week. You know, MSK is one of their 6 major conditions, so it's not, this is great news for us in terms of keeping MSK at kind of top of people's minds.
Kate, thank you for that that really insightful answer. We've also got a question about how do you intend to continue using co-production to support the framework?
Thank you. Great question. I'm so pleased to get questions about co-production, because it is something that I'm really proud that our lived experience partners were valued members of the team and of the programme. Paid members. This is not a voluntary, you know, they are needed. People with lived experience are integral to being able to develop national policy. I don't know how we think we could develop policy without listening to people and who are living with these conditions and associated difficulties and issues every single day. So it makes absolute sense to me. We should listen, we should be co-producing at a local level, not just a national level. I know it's difficult, and I know we can get it wrong. I have done it. I made a right mess of co-producing something a few years ago, but we learn, and we got it right. We went again. It's not always easy, but it's absolutely the right thing to do. So next steps for us in terms of co-producing and working with people is where we have the crowdsourcing platform, #SolvingTogether platform, and we're using that starting next week, I think it is, for the next month, to hear people's ideas and views about how we can enhance self-referral to community services, MSK being one of them. We know absolutely that self-referral and open access for services is not new. We were doing it 10 years ago when I was working in community services. We know it's always been there, but it's not universal. So we need to hear from people what would make it easier for you to be able to access a service. Where's it working well? Where have you made a bit of a mess and you've had to you've gone down a rabbit hole somewhere? Let's kind of share this learning and listen to people's views on what would make it easier for them. So that's how we're it should be absolutely business as usual, working with people and lived experience partners, and we should be doing that not only at a national level but at system and local level too.
Thanks, Kate. We've got time just to cover a couple of questions, and please do keep them coming in the Q&A. A bit of a curveball, it's a bit like getting a politician on TV and you ask something that's slightly off script. But Kate, you may be able to help us with this. What is the status of the best MSK health programme? And if it's outside your bucket, then we'll move to another question.
It's a little bit outside my bucket. The programme has shifted, has reduced in size and has shifted to working alongside GIRFT and ourselves in community health services. As you'll know, NHS England as an organisation is going through a consultation, and we're having some organisational change in terms of developing the new NHS England, and so I can't tell you what that's going to look like, but I can tell you that it's in the mix. And I think that even the government strategy, including MSK as one of its 6 major conditions, is a really positive step, but it is just a little bit out of my remit, Ian, for me to know any more detail than that.
No, that's fine. Hopefully that's helpful for the person that asked that. There are some other really good questions, but I think actually it will be good to hear a wider range of responses as well as Kate. So I'm going to save those questions for the plenary at the end, but thank you for them. We'll put them to Kate and our other colleagues to get a broader perspective. So we're going to move to our next speaker now, Matthew Carr. Matthew is the Clinical Director for NHS Sussex and Sussex MSK Partnership East, and he's going to give us a whole systems view, optimising opportunities downstream to alleviate pressures upstream. Matthew.
Brilliant. Thank you, Ian, and great to see so many people here today. I'm mindful we haven't got very much time, and I'm mindful everyone's given up their lunchtime. So what I intend to do is just use the next few minutes just to share some of the experiences we've been through in Sussex, where we've taken a whole system view of looking at MSK services across primary, community and secondary care, to really realise the greatest opportunities that we've experienced across those care settings in making sure we use our community workforce in the best way to maximise the impact on our secondary care services. So I've just got one slide to help visualise that. So can we move on to that, please? So what I'm trying to illustrate with this slide is really a focus for us to really think about the opportunities against the care needs of our patient cohorts that we're seeing in the different care settings, because we've got to recognise that it's the patients that we see in those areas have different needs. So if anyone was fortunate enough to go to the MSK conference in November recently, you might have heard some Amy Robson talk about how actually in the way that we're currently delivering MSK services isn't really getting the greatest outcomes for patients if we focus our outcomes on how patients recover well or live well with MSK conditions, focusing on disability adjusted life years. And when you really drill into the data, it really stands out that what we're not doing very well with our MSK services is always we are not always making sure we address the environmental and social factors that contribute to someone living well or recovering well from MSK conditions. And if I reflect on my own journey as an MSK physiotherapist, when you're new and novice, you want to be that expert in clinical reasoning, in anatomy and physiology, that there's I think my experience was that there's less focus on thinking about how does the patient's environment and their social factors impact on their recovery and their ability to live well with MSK conditions. But then if we think about how that varies against the patient cohort, so in primary care, I would argue that because of the lower level of clinical complexity, we've got a greater need to focus on those environmental and social factors. And as we move through community and secondary care, the clinical complexity becomes greater, but there's still always a need to focus on those environmental and social factors if we're going to see meaningful patient outcomes for our population. So that's where I'm sort of positioning the opportunities. And we touched on what can community services do to alleviate pressures within secondary care. So for me, in primary care, what we've experienced in Sussex is we really need to make sure we get the foundations right. And for me, getting the foundations right is about making sure we've created the infrastructure to have truly integrated FCPs. So when I say integrated, what I'm talking about is really developing roles where our FCPs have job plans where they work across the primary and community care setting. Some of their time sitting in community, some of their time sitting in primary. And within one patch of Sussex where we've worked really hard to achieve this, we've been able to make sure we've got that model of care evident in 8 out of 9 of our PCNs. And it just reaps so many rewards in terms of it allows our FCPs to maintain their rehab expertise. It allows our FCPs to understand surgical thresholds and make sure expectations are set in the right way for patients at the very first contact. So getting that foundation for me is really critical. It takes a lot of energy and a lot of influence, but it's well worth it, reaps the rewards. But focusing on that greater extent of environmental and social factors that we're likely to see in primary care, for me, the other thing we need to make sure we do with our community clinical workforce that sit in primary care, we need to really support them to become our personalised care champions. They are the cohort of they are the clinicians that need to make sure their clinical reasoning with that patient is a really holistic approach to clinical reasoning, really understanding patients' values, preferences and contributing factors, and making sure that they, if they are not the experts in delivering some of those needs for patients, they recognise that they are absolute needs for those patients and they work towards finding ways to achieve that. So we know that the expansion of ARS roles has allowed primary care to explore health coaching roles and social prescribing roles, but we know it's very variable in terms of how they're delivered across primary care. So where we are right now, I think our MSK clinicians sitting in primary care need to be given the space to develop really strong relationships with health coaches and social prescribers where they exist. But where they don't exist, they need to be the champions that influence the decision makers within primary care to the value and the need of those roles. So they need to be the people knocking on the clinical director's doors saying, look, I've got these patients with these needs and I can't do anything with them because we don't have the right workforce in primary care. So for me, that's the greatest opportunity in primary care to help improve that flow of patients and optimize that care at that point. If we then move on to community services, which is where we'll see a greater level of clinical complexity, but still those factors that need to be addressed in terms of environmental and social factors. For me, the biggest opportunity, but probably also the biggest challenge for our community team members is really recognizing there need to be absolute rehab champions. This is the space where we need to support patients with non-interventional clinical care to achieve their greatest health, to help them return back to their previous levels of function, allow them to live well. And we can only do that if we are giving patients the right level of personalised rehab. And I've personally seen some of our rehab expertise diminish over recent years based on the push for productivity over quality. And we haven't helped ourselves here in the MSK space because we don't define a consistent approach to defining value and impact with rehabilitation, and we deliver quite variable care. So for me, a big opportunity in supporting that optimal care is to make sure we challenge our community services to really demonstrate their rehab expertise, to allow them to modify care and stratify care so the right level of input goes into the right patients, But to do that, we've seen real value in making sure the community service has a dedicated data resource. So what I'm talking about there is almost a business intelligence team that sit alongside our community services that allow accountable clinical leads to really track patient progress and be able to evidence that patients are actually achieving a positive outcome from their community care, and have allowed and have been able to use that data to evidence that patients are achieving that real meaningful change. In Sussex, we're fortunate, we have a digital program capturing data across 5 of our community services, and it's not great. At the moment, it's showing that 12 weeks after starting a community episode of care, only around 55% of patients are saying that they feel that they're in a better place than when they started. About 30% are saying they've seen no difference, and about 20% are saying they're a bit worse. So for me, that data speaks volumes and will allow us to really drill into who are those patients that aren't achieving that meaningful improvement? What can we do differently to support their needs? So data is key, but rehab needs to come back up the priority list for our community services and be an absolute linchpin of what we deliver in community care. And then finally, in secondary care, with arguably the greatest level of clinical complexity, I think the greatest opportunity is to really ensure that there's secured commitment from our secondary care colleagues to support our community teams with routine and localised interactions. Now, the reason I've highlighted routine and localised is because if we focus on the routine, people change, people develop, workforce changes, and it takes time to build that confidence in those relationships across those 2 teams. So unless we have routine, committed time from both parties, we won't develop the required confidence and effectiveness across that interface between community and secondary care. And that has been, for me, a real big challenge to make sure we can secure that regularly in our consultant and our registrar's job plans. So that's something that I think is a real need. But also I think there's a real need to localise those interactions, because there's a lot of evidence out there around building effective learning cultures, building effective educational alliances between 2 teams. And you can only do that if you really understand who are the people in your team, how do they learn, how do they work, and how can you build a space for effective learning across those 2 teams. So in that sort of, to summarise, so those greatest opportunities, I think primary care, integrated FCPs across the primary community barrier, really being our personalised care champions. Community services, really fly the flag for effective rehabilitation, but make sure we've got the dedicated resource and data to allow us to demonstrate that it is indeed effective. And in terms of secondary care opportunities, really working with our secondary care colleagues to secure their time and commitment to routine interactions. So thanks ever so much, and I'll probably hand back to Ian.
Matthew, thank you, and a very succinct summary. Thank you for bringing that all together. One of the questions that's come in is, of those opportunities in those different spaces, is there one that you would pick out that's going to have the greatest impact on alleviating elective care pressures?
Yeah, challenging question, that one, Ian. For me, and I'm sorry to my community colleagues out there, but I think the focusing on our community setting is the right place to focus the priority. Because for me, those community clinicians, they are the linchpin that can help to inform and educate everything that happens before in primary care. And they are the influencers that can really affect improved interfacing between community and secondary care services. So actually for me, it would be making sure that we really give the community team the space and the autonomy and the resource. It's often an under-resourced area, to recognise that they are likely to be the team that can have the most amount of impact in improving things both upstream and downstream in that whole MSK programme.
Brilliant. Matthew, thank you for those insights. And we're going to move now to our next speaker, Andrew Cuff. Andrew is a consultant physiotherapist and head of MSK at Connect Health, and his talk is about embracing synergy, breaking down silos. Is it time to do things differently? Andrew.
Thanks, Ian. I've got a few more slides than Matthew, so I'm going to have to channel my next slide, please, voice, but hopefully you can hear me okay. So we go to the first slide, please, Jen. Brilliant, thank you very much. Now, I previously spoke on a Connect Health Change webinar about the productivity curve and accountability, and how in a time where there's more demand than ever, with capacity it's most stretched, we need to do things differently. We need to stop doing things that don't add value, and double down on the things that do. So my thoughts, or my 5 minutes or so today, are to hopefully stimulate thoughts and consider possible avenues for reform that our healthcare system so desperately needs. Now, this image on the slide is from the MSK Services Framework, published 17 years ago. It describes a predominantly community-based pathway that facilitates self-management, draws on a wide-ranging number of professions across primary, community and secondary care, interfacing with a number of different health, social, local authority and third sector agencies. And having discussed this with our CMO, Dr. Graham Wilkes, he made it clear that, well, really this narrative sounds a bit too familiar. So if I go on to the next slide, the question that I would like to ask is, if we started with a blank sheet of paper, would we design MSK pathways as they are now? Next slide, please, Jem. Now, this image here is from Google. It was chosen as the kind of the first one that came up, but I probably could have used any community MSK pathway to try and highlight my points. So this image on the screen is only a year or two old. So again, it describes a predominantly community-based pathway. It talks about facilitating self-management. It talks about drawing on a wide-ranging number of professions across primary, community, secondary care, interfaces with social, local authority and third sector agencies. So, as an MSK community, have we progressed our thinking across the last 2 decades? And next slide, please, Jen. So, if we started with a blank sheet of paper, could we design community pathways as they are now? And that's kind of got me thinking. So, the pathways I've just shown that demonstrate flow from primary care through community into secondary care, was that unique to the MSK world? And if not, could there be some learning here for us as an MSK community from other specialties? Next slide, please, Jim. And again, I'd like to thank Google for these examples of frailty and diabetes pathways. But what's interesting is, again, these examples describe a predominantly community-based pathway, facilitating self-management, drawing a wide range number of professions through primary to secondary care, interfacing with third sector, local authority, health and social care. Next slide, please, Jem. So to answer my question, it appears that we would, and we do design pathways in the same way that we have been doing so for a number of years across specialties. Now, that kind of makes sense, given that we will apply a frame of reference that we're familiar with, and that we would anchor to with all of our underlying biases and outlook. And of course, across the pathways I've just demonstrated as examples, there's evidence of both impact and effectiveness in each. But the key question is, could we do better? Next slide, please, Jim. So what I'm going to propose to try and stimulate some thoughts draws upon concepts and principles that aren't new, and a fair number of them are laid out in this excellent paper from ARMA, published 4 or 5 years ago. We know that MSK pathway redesign isn't new, but from what I've just demonstrated, we seem to be constrained by our siloed thinking. Next slide, please. So on the screen now is the infographic outlining the Core 20+5 approach to actioning health inequality improvements. And one could argue that MSK should have been considered as one of the key clinical areas. MSK conditions are very common. They affect 1/3 of the population, and this rises to 2/3 in the population over the age of 65. But that's not why I'm putting this slide up. We know the same health inequalities that are seen in many long-term conditions are also seen in chronic musculoskeletal pain. Musculoskeletal pain is associated with deprivation. More people in the most deprived decile report chronic pain than those in the least deprived decile, and with a greater prevalence of comorbid mental health conditions. But all I wanted to highlight is how the concept of health inequalities have been recognised as a cross-cutting theme through 5 key clinical areas. And this concept of cross-cutting themes, I think, could be championed more readily. Next slide, please, Jem. So, for example, in this thought piece from the King's Fund, it's highlighted how far more can be done at a national level on primary prevention of cardiovascular disease. It talks about bolder, evidence-based public health policies that are needed to reduce risk factors such as smoking, poor diets and obesity, which would reduce prevalence of other leading causes of morbidity and mortality, so cancer, dementia or diabetes. And interestingly, there's no mention of physical activity or exercise within this document, and that's despite physical activity reducing all-cause mortality by up to 30%, significantly reduces the risk of not just cardiovascular disease, but also other long-term conditions such as diabetes, depression, dementia, frailty, fragility fractures. So it would appear that things like increasing physical activity, as well as reducing smoking, improving diet, and maintaining a healthy weight, will have a benefit across a number of long-term conditions. And on to my final slide. So what does this mean for MSK and supporting elective care? Now, the blue bubbles on the slide draw on recommendations from a number of best practice clinical and public health guidelines. So lower back pain, osteoarthritis, multimorbidity, hypertension, diabetes, and physical activity. And they are the cross-cutting core high-value interventions that address both risk factors and contributory factors for a number of long-term conditions, including MSK. And not just the conditions I mentioned here, but also cardiovascular disease, depression, diabetes, and frailty. Now, if I see somebody in clinic with back pain, arthritis, or tendinopathy, I'll be discussing physical activity, positive lifestyle behaviours, maintaining a healthy weight, work, or valued activities in a way that matters to them and in a way that's accessible to them. That person will also likely be receiving similar advice from their diabetes team, their cardiovascular team, their mental health support worker. So what if we could design a pathway that removed duplication, particularly for those with long-term conditions? One that enabled people to be supported and benefit from these high-value interventions in a way that then ensures specialist care could be provided with both trust and assurance that the cross-cutting care has been both addressed and optimised. So the rheumatologist focusing on medical management, the pain clinician working with the person to accept and commit, and the MSK clinician focusing on that individualised exercise prescription or champion the rehab that Matthew has spoken about. So the question for me is it time to adjust our frame of reference and to finally reach for that blank sheet of paper? Thank you.
Brilliant. Thank you so much, Andy. Apologies, Andy's screen appears to have frozen, but we can hear you clearly. So
Okay.
we'll carry on. We've got just playing to your last slide about cross-cutting interventions. I mean, it's lovely to hear a novel way of looking at this, and of course, from a patient's perspective, they are seeing quite likely to be seeing multiple specialists who are all trying to give very similar advice. So, what would your proposed first step be to progress your thinking around this to make this a reality?
Yeah, sure. I think to answer in one word, it would be influence. So if I reflect on the number of ICBs, ICSs that are currently redesigning MSK pathways, and some that obviously I'm involved with, if you look at how that's being approached, then largely it's looking at what's currently being provided in an area, what's currently working well, and trying to piece that together to take the things that are working well and do more of them. And that's not a bad idea. But that same work that's happening in MSK is happening in other long-term conditions as well. So I think the first handle step for me would be to call it out, but also to step back a little bit and think, hang on, are we not going to be making the same mistakes again here if we continue to pursue down this route? Could we embrace value? Could we look for opportunities of synergy, look for opportunities to reduce duplication, and just be a bit brave in terms of maybe doing things a little bit differently?
Brilliant, thank you very much, and apologies for the technical difficulties. We're going to move to Sharon. Sharon Barrington is Head of Planned Care and Long-Term Conditions at Buckinghamshire, Oxfordshire and Berkshire West ICB, affectionately known as Bob. And her talk is about how MSK has impacted secondary care. Sharon.
Thank you. Good afternoon, everyone. So just to give you a bit of background, Bob, Buckinghamshire, Oxfordshire, Berkshire West, Bob ICB as it's known, has come into existence with all other ICBs on the 1st of July. It has a population of around 2 million patients, so it's quite a large ICB in the grand scheme of things, made up of 3 counties, as you probably recognise, Oxfordshire being the largest of those with 800 registered population, just over that. Berkshire West 600 and Bucks 560. Obviously that's a moving feast. Can I have the next slide, please? We have 3 main acutes, so Buckinghamshire, Oxfordshire University Hospitals and Royal Berkshire Hospitals, and you'll see I've got a few graphs for you, death by graph really, but hopefully you can understand the impact of MSK on trusts and on their waiting times. So I'm just going to quickly run through the COVID recovery, look at some of the positive impacts of community MSK, which has been quite successful and hopefully more successful in the future, looks at some audit results that we did and some final thoughts. So next slide, please. So the first graph just shows you obviously the impact of COVID really. You can see 2 big dips there. This is the community MSK service, and obviously all of those patients either stayed at home or went to their GP and weren't referred or didn't self-refer, most likely stayed at home. So that had a big impact and a big build up later. If we could go on to the next slide, please. So here we're looking at the rheumatology services across the 3 trusts. So I've joined them all up together. You can see again the similar picture dropping down in from February onwards down to April, a gradual recovery, but you can see actually the recovery, and this is quite up to date, so it's to November, it hasn't recovered fully yet at all. And then the 2 graphs together put together, so one shows the over 18 weeks. You can see the over 18 weeks have had a bit of there were some initiatives sort of in the middle there, sort of October, February 22 and October 21 sort of time, and then activities dropped off again. But you can also see that the less than 18-week waits have increased, the activities increased, sorry, and actually increased slightly more in November, which is slightly different to you might expect really. You would expect maybe some more activity in the greater than 18 weeks category, because that's the bit that's supposed to be recovering as quickly as possible, with no 78 weeks by the end of March. So you can also see in the bottom graph that actually things have bobbed along and not quite got back to where they were. So next slide, please. And this is the incomplete. So this is the waiting list. So again, you can see good recovery in the 65 weeks. So lots of patients being seen there. Good recovery in the greater than 78 weeks and 52 weeks, probably the biggest impact. But then obviously coming up behind that are all those patients coming through to the service that are still waiting. And actually that number increased until September 22, when actually there have been some really good initiatives in rheumatology. And I could talk on, for another session on what rheumatology have done to improve their services post-COVID. So next slide, please. So Truman Orthopedics, similar sort of picture, but actually they're non-admitted, recovered. Again, quite a slow recovery, didn't have the same sort of dip that other areas did. They carried on, although a gentler recovery. You can see again in the one below, the non-admitted patients carried on seeing patients and saw a relative increase in the greater than 18 weeks there. On to the next one, which shows you the admitted. So again, activity hasn't really recovered back to the pre-COVID levels in admitted. It's sort of getting there, but not quite there. November looks a bit more promising. There was a bit of extra work in May, probably some waiting list initiatives with Saturday working and so forth. But some theatres have been out of action. And remember also that the infection prevention and control measures were in place as well, which have limited the number of patients that can be operated on in a session and seen in outpatients. So the lower graph just puts them, breaks them down into the two, and actually you can see there that the number of pathways in the greater than 18 weeks has increased, but the number seen in less than 18 has reduced. We go on to the next slide. The incomplete pathway, so the waiting list for Truman Orthopedics, which is quite stark really, sort of increasing from May 20 onwards, although you can see in the longer waiters in the lower graph for 78, 65 and 52, they are reducing. 78 weeks there were probably less patients, but to reduce by, but obviously the patients coming up behind are still quite in very large numbers, and they're obviously going to become, if they're allowed to, the next 65 weeks, 52 weeks and so forth. So if we just go on to the next slide. So we looked at our MSK referral profile, so looking at the referrals into the MSK service, 40%, 40.1%, 40.8%, sorry, 41% were referred to orthopedics. Out of that was a total of 25,000 patients, and the next highest were to physiotherapy, as you might expect. Rheumatology were relatively low referrals, but actually the referrals onwards were quite high. So 89% of referrals that were referred for a rheumatology opinion were then referred on to rheumatology. Pain management, again, a very similar picture, not quite such a high percentage, but more than half were actually referred onwards rather than either being seen in the service or managed in a slightly different way. So I think, and then after, so that was at triage, and then after referrals seen, actually after the triage in the service, there were 5,000 of those referred on again. So quite a high percentage referred on, but those two particular areas we looked at, pain management and rheumatology, because we felt actually there might be some opportunities there. And the rheumatologists and the pain management consultants and the pain management service, which is run by the Nuffield Orthopedic Centre in Oxfordshire, were really keen to look at that because they felt actually they were getting a lot more referrals than they felt they ought to, and some of them they felt could be managed differently. So we, if you go to the next slide. So the audit results. So we have referral pro formas. So we looked at the pro forma as a group to improve the quality of that, to get better information for triage. Suggested that more face-to-face assessments would be appropriate because there were lots of people just being referred on from the triage point, but actually if there wasn't good information in the first place, it was very difficult to make that decision about where they should go. They should improve links with the triage. So the audit was done by some of the MSK providers, physios in the community, and also by some of the secondary care staff. So it was a joint audit. They recommended, which is fairly obvious, I think, really, is that they should do some more joint working and education, and they should also strengthen their onward referral information. Care and support planning should be embedded in the pathway so that it's really clear about what the patient wants to get out of it, and make sure that the patient is supporting what happens next. They didn't have shared decision making at this point in time, so there was a relative an amount of shared decision making, but that's been improved quite considerably. So from the audit, a sample of 53, 11 referrals they felt the auditors felt should go to level 1 physio, which and they were referred on to rheumatology. And then in the pain service, 17 they felt should have had level 1 physio, and because they hadn't had that in the before the getting referred onwards. The outcomes from secondary care after the rheumatology patients were 18 were discharged at the first appointment, which suggests that potentially there could have been another opportunity there. 7 were referred to physio and 7 were referred to pain management. So I think just looking at that kind of made us think, well, actually, maybe there's some opportunities here for more joint working. So if we just move on to the next slide, which should be the last one. So just final thoughts. Good triage is an essential part, I think, of the process, and a conversation with the patient, whether virtual or face-to-face, also adds value to that, particularly for those complex patients. We need to manage the risk across the system, so we need that joined up approach, and I think between acute and MSK and primary care to ensure that those patients are getting to the right place first time. Those relationships are essential for working well, I think, and I think moving forward that has to be the kind of, that's what integrated care system's all about, isn't it? And we've obviously got the acute provider collaboratives being developed, and I think that's another way of kind of getting services to work together. And one of our acute provider collaborative are keen to look at MSK across the board in Bob. Just going forwards, so there's quite a bit around digital innovation. Patient expectations vary enormously, we found, and working on, talking to patients, getting a personal care plan in place, and also shared decision making is essential for that. Those prevention conversations, and I know you were talking about that earlier, making every contact count. I think sometimes the more opportunities there are to have that conversation might start to make patients think about changing what they're doing and how they might do it in the future, and giving them opportunities to make that change. And what the real changes really need to make that kind of move to the left and get taking that population health approach with prevention and education and incorporate into it. And obviously that's something that we've kind of worked very hard with our providers of MSK to deliver on. Okay,
Sharon, thank you so much indeed. A whistle-stop tour through the data there, and the audit was very interesting, and the conclusions obviously are going to inform what happens next. I'm going to just go back to some of the questions that have been coming in during the presentations, and there's been quite a lot of discussion around what's been called the third bullet point. This is around the definitions of priority patients in the framework document. Now, I'm going to ask all of our colleagues on the call to have a think about what the definition of patients with acute and/or complex needs with high levels of pain leading to significant loss of function and/or disturbed sleep. I'm just going to ask colleagues to have a think about how they're going to implement that. The framework gives a lot of flexibility to interpret this locally, and that's the intention. I'm just going to ask Jen if you could possibly find that slide. I believe it was slide 12, because I think it would be helpful for people to see what we're discussing. And I'm going to ask Kate to field that question first of all, whilst we'll just wait for that slide to come up. Sorry, got to scroll backwards. So Kate, what's your thoughts about the definitions of priority? This seems to be taxing providers, so it would be really helpful to hear what the intention was around this.
Yeah. Well, you'll know the extreme lengths we went to in terms of developing even these 3 definitions in as someone as part of those conversations. This is an easy task. We're you know, it's a little bit like developing acceptable weight thresholds rather than standards. It's absolutely meant to support conversations for local systems to have to, you know, it is what it says on the tin. It's a framework, and so it's meant to support in being able to kind of stratify your list of people waiting, so that you can locally manage that more effectively within those terms. It's not easy. There's no easy fix, is my answer, but this is a start of a 10 for you.
Brilliant, thank you. And your slide did say that you know, people had to take into account the resources that they had available.
Yeah.
So I'm going to ask our other colleagues on the call, and we can come off the slide now. I think people know what the question is. So I'm going to go to Matthew next. How would you, Matthew, interpret that prioritization framework?
Well, for me, we firstly need to acknowledge it's open to some level of interpretation, so we need to treat it in that way. And secondly, we need to trust our clinicians. We need to trust our clinicians to be able to make those subjective decisions around, do they consider that the patients fulfill those criteria. But the third thing I think that really adds a lot of value here is data. I can think of similar examples where we've done work in this space, where we've used data to track individual variation in terms of how many, for example, triaging of referrals, how many are placed on an urgent list versus how many are placed on a routine. So as long as you've got a safe space for sort of sharing learning, actually you could use the data to sort of help anyone who's an outlier, either not highlighting enough urgent patients or highlighting too many, to make sure that there's a level of consistency in how that subjective item is interpreted. So for me, data is key.
Thank you. Andrew, what would your thoughts be about setting a framework, you know, putting this framework into practice?
If you're, I'll try and just add maybe something to Kate and Matthew's answer. I thought they were really nicely comprehensive and pragmatic in approach. I think the key kind of dependency for me on this is the quality of the referral. I think Sharon mentioned this previously, because particularly as a triaging clinician, I don't necessarily always get enough information to be able to understand the impact of symptoms upon the kind of criteria outlined here. So there's an element around kind of referral quality, referral optimization that allows you to get a bit of a feel as a triaging individual as to whether or not somebody does meet this priority definition. But then obviously to Matthew's point about trust, data, but then equally, if we're utilising kind of more digital innovations, how do we ensure that any kind of digital triage platform that may be in place also reflects this priority? And I think that's something that's probably being considered across a number of providers at the moment, particularly as we've seen the increase in digital uptake both during and since kind of pandemic to aid recovery.
Thank you. And Sharon, was there anything that you would like to add to how you might see some local flexibility in interpreting this prioritization framework?
Yeah, as you say, I know everyone said really it's a framework, isn't it? So I think it does need to be interpreted based on the individual patient and personalised to that individual patient. With good quality information, you can make that decision much more easily than if you're faced with a see and treat type of a referral. Brilliant, thank you. We've got one other topic that I would like to really ask all of our colleagues to have a think about, and I'm going to line up Matthew to start us off talking about FCP. So we've had quite a lot of questions about that. So one question was about staffing levels that you've had in Sussex in order to have that split between community and primary care working. You know, I suppose it plays to the variations in funding level across different settings of care, and
there's also a question about, well, what happens if your PCNs are not engaged and don't see the value of FCP? So perhaps we could take those two questions hand in hand. Give us your thoughts about FCP.
Yeah, thanks, Ian. I think staffing levels is a real challenging one, because historically primary care often want more than community services can deliver. So there's a thing there around forming a good alliance between the community service that want to provide and the primary care system that won't. But for me, there's a real what's worked really well is where community have helped to define what the staffing levels need to be to work to deliver that effective and integrated workforce. So I think community services can take the sort of bull by the horns and drive that decision making. Primary care have the funds to often then say yes or no as to whether they want to make that work. I think in regards to the resistant primary care networks, when they don't see the value of FCPs, I think the thing that strikes me most here is that where are primary care networks in their maturity? And they only became a statutory ICBs as an entity only became a statutory body in July. So primary care are still struggling to sort of find their place and their voice. But actually within the development of an ICB, there is a lot of energy around being able to sort of identify who is a key decision maker around influencing policy at primary care level. So I'd say any community services struggling, reach out to your ICB colleagues to say where is this work happening, who within the ICB can we engage with to sort of challenge that thinking and to strengthen the value of FCPs working in primary care.
Fantastic, and that's a great segue to bring in Sharon. So and Sharon, we've also had a question in similar lines to what is the impact of ICBs and what is it going to have on MSK services? Does it play to Matthew's point around increasing uptake of FCP?
Okay, I mean, one thing I think is really clear is we can't have FCPs working in isolation. They've got to be supported and part of a system approach rather than just working in a GP practice on their own, because the support and obviously the education and so forth are kind of not there as as they might be in terms of how they act. So a system approach. So I think there's got to be some work done by ICBs, or certainly our ICB have got to be looking at kind of outcomes across the system, making sure we've got some outcomes in place in the first place, because not all of those, all of the services have that. We've got 3 different providers, and one of our counties, Berkshire West, has a AQP system, so they've got a large number of physiotherapy providers, again, working potentially out in isolation, although one provider might provide quite a large percentage of that care. So I think it is about reducing variation for the population, making sure shared decision making and all of those kind of recognise, the prevention elements, they're all kind of supported in the model. And well, yeah, I think there needs to be some sort of network approach as well across the system and system-wide ICB. I mean,
final thought from Andy about FCP, and then we will wrap up.
Yeah, thanks, Ian. I just wanted to pick up the point on the question about what to do if the PCN don't see the benefit to FCP physiotherapists. And I might take a slightly controversial stance on this, but I don't think they necessarily always need to see the benefit of an FCP physiotherapist. So ARS funding as a bucket is up to the primary care network currently to define how they best spend that resource. And it may be that if you have a functioning community MSK pathway with readily access to self-referral, but don't have some of the roles that Matthew was talking to around social prescriber link workers, health coaches, actually the funding may be better spent to support personalised care in those newer roles for that primary care network. So I think it's taking a system-wide view, working with partners across primary care and community care to understand, well, what's going to add benefit to the population, the answer to that question may be FCP. It might not also be FCP.
Brilliant, thank you. And we've come to the end of the webinar, so a very great thank you to all our speakers, to Kate, Andy, Sharon and Matthew. Please don't forget to fill out the feedback survey, just 2 minutes of your time to help us improve our future events and understand what topics you'd like to see covered. And look out for the recording. What we will do, that we've had lots of questions that we haven't covered on the webinar. We will provide written answers. Our speakers will help us complete those answers, and we'll publish those, and they'll be on the webpage soon. Our next webinar is on the 1st of March, and it's entitled "Can Health Coaching Reduce Primary Care Pressure and Improve Patient Outcomes?" So we look forward to seeing you there, and thank you again for your contributions today.